My name is Sarah Scott and I'm an ST6 trainee in Anaesthesia and Intensive Care Medicine, currently working at Freeman Hospital in Newcastle. In this talk, I'm going to look at intracranial pressure, what it is and why it's relevant, how we can monitor it and what to look for when you're monitoring, and then finally I'm going to discuss a little bit about how you manage raised intracranial pressure, and this will mostly be in the context of traumatic brain injury. So I'm aware you're going to have a talk on CNS physiology, so I'm not going to take up too much time reviewing that information during this presentation. But by way of introduction to the topic, I'd like to highlight the Monroe-Kelly doctrine, which I'm sure you're already familiar with. This model describes the relationship between the skull, the cerebrospinal fluid, the brain parenchyma, and blood. So normally these exist in equilibrium. Therefore, if the volume of one of the CSF, brain parenchyma, or blood increases, then another must decrease. The CSF, the cerebrospinal fluid, is a dynamic pressure system, and your normal values for your intracranial pressure as an adult are between 5 to 15 millimetres of mercury, and for infants here under a year, it's 1 to 4 millimetres of mercury. So you can see on the picture on the right of your screen, in the normal state, as I mentioned, these all exist in equilibrium. Whenever you have an increase in one of these components, so as you can see in the middle of the three images, there is now a purple component which is representing a mass. So in order to maintain the intracranial pressure at within the normal limits, some of the venous volume and some of the CSF has exited, and that's then allowed the pressure to remain the same despite having to compensate for this increased mass. If you then look at the bottom of the three images, you can see that the mass is increased in size and it's squeezing out even more of the CSF, even more of the blood volume, and this is now a decompensated state. So I'm going to show you in the next slide how this appears. So you can see on the y-axis you've got your intracranial pressure, and on your x-axis you've got the intracranial volume. And again, slightly different colours representing different components, but pink for the brain tissue, blue for the blood, and yellow at the top for CSF. So in image 1, everything's normal. As you move along to the right, you start to see a little brown spot appearing, so you've got a mass, which is an addition to the components which are normally in equilibrium. So the pressure starts to increase. As this mass gets bigger, it increases the pressure further, and then it reaches a point where a very small increase, excuse me, a small increase in size of the mass leads to a large increase in intracranial pressure. So indications for monitoring ICP include traumatic brain injury, and this may be in the context of a severe head injury where the patient cannot be serially neurologically assessed, which may be because they have either been intubated and ventilated or they're unable to comply with the examination, or a severe TBI where they've got a Glasgow Coma score of less than 8 with an abnormal CT scan. And what we mean by that is the presence of a hematoma, contusions, swelling, herniation or compressed basal cisterns, or a GCS of less than 8 with a normal CT and 2 or more of age over 40, systolic blood pressure of less than 90 millimetres of mercury, or abnormal motor posturing. It can also be used in patients with hydrocephalus or impending hydrocephalus. It has on occasion been used for stroke patients, and it can be used in encephalopathy. So this diagram just gives you a crude overview of the brain. So you can see the labels in blue are identifying different parts of the brain, and the labels in green just demonstrate different ways in which you can place ICP monitors. So you can have an external ventricular drain, it can be tunnelled, or you can have an epidural or subarachnoid bolt. I'm going to talk a little bit more about some of these shortly. When considering any intervention, you have to weigh up the risks and the benefits. So I'll start with the benefits. You can have a continuous measure of ICP if you put in a monitor. In some cases, this can give you a visual waveform or it can give you a number. And this can be used to guide therapy. So if you see increasing ICP, which is dangerous for the patient, you can then intervene, do something and try and reduce the ICP. For many of these patients, you can't always examine them, so many times they are intubated and ventilated, so you may not see subtle clues that the intracranial pressure is rising before it's risen to a very high level. And with some of the monitors, you can drain some CSF or you can administer drugs into the CSF. So that would be beneficial in certain patient groups. As again, with any intervention, you've got to weigh up the risks to the patient. So these are invasive monitors, and with anything invasive, there's a risk of infection and a risk of bleeding. There is not very much evidence to suggest that these improve patient-centred outcomes. So there's a potential that you're treating the numbers, but that it doesn't translate into improved patient outcome at the end of everything. There is a risk of drift or of misinterpretation of the ICP, and if you start to think that the ICP is increasing to a dangerously high level, this may prompt you to do some interventions, but if you've misinterpreted the graphs or misinterpreted the trace, you may end up doing something harmful. And then there are risks associated with individual devices. So in the context of the bolts, you can't calibrate them. They're not a global measure, so they tell you about local changes only, which may not reflect the entirety of the brain. It doesn't give you any information about local perfusion, local metabolic activity, or oxygenation. You can't drain any CSF, and there is a risk of drift, which increases the longer that the bolt remains in situ. For an external ventricular drain, you need generally to take these patients to theatre to insert the drain. So you need the resource of the surgeon, they need just the theatre team. It's a slightly higher risk of infection because you've got a direct connection with the CSF. And as with anything, although it should be clearly labelled, different colours, etc., to stop you inadvertently administering drugs into it, as with everything in medicine, if there's a chance that it can happen, it will happen, and so there is always a risk that drugs can inadvertently be given into the CSF when meant to be given intravenously. It can be technically challenging, so if the patient's got small ventricles or they've got a lot of cerebral edema, it may be a technically difficult procedure for the surgeon. So I'm now going to discuss some of the monitors in a little bit more detail. So this is an external ventricular drain, which is a temporary system that allows you to drain CSF from the ventricles into an external closed system. So it comprises of a measuring chamber, which is connected to a drainage bag. There's also a sampling port, which you might be able to see sort of halfway between the patient and the drainage system. You have to make sure that you zero the chamber, so this needs to be done at the level of the external auditory meatus, and then this allows you to increase or decrease the height of the drain, depending on whether you need to drain more or less CSF. It's a gold standard because ventricular pressure is more reflective of the ICP than subdural, extradural, or subarachnoid pressure. It's inserted in theatre, as mentioned, and via a burr hole, and you have a catheter then placed into the lateral ventricle. The transducer is remote from the patient, however you can transduce the tip. There are, as I've mentioned, there is a reasonably high infection rate, so 6 to 11%. This is increased if the drain blocks and it's flushed, and it increases further after day 5. So Neuro devices are impregnated with antibiotics such as clindamycin or rifampicin. It shouldn't be inserted if the patient has a coagulopathy, as the risk of bleeding is increased. Moving on then, this is an ICP bolt, which is a strain gauge tipped catheter, which goes in through the frontoparietal suture line in line with the pupil. So it goes through the dura either into the CSF or intraparenchymally. And whilst the EVD needs to be inserted in theatre on most circumstances, the ICP bolt can be put in at the patient's bedside. It's zeroed at the level of the external auditory meatus, but one of the disadvantages of the ICP bolt is that it may underread when pressures are greater than 20 millimetres of mercury. And as you know, the normal is between 5 and 15, so you're really not looking at a massively big increase before the accuracy of the readings starts to potentially become less. Once it's inserted, you can't calibrate it, and the ICP bolt can have a baseline drift, and this is more likely to increase after the 5th day of insertion. So you need to be mindful again of your readings and how long it's been in situ. So when you have an ICP trace, there are a number of different waveforms. So there's phase P1, P2 and P3, and with different names, so percussion, tidal and dichrotic. And the normal ICP trace should be pulsatile, which reflects both the cardiac and the respiratory cycles. The percussion wave correlates with arterial pulsation. The tidal wave is generated by arterial pulsation and the resistance from the intracranial parenchyma. So it represents intracranial compliance, and the P3 dicrotic waveform represents the closure of the aortic valve. The respiratory component is generated by changes in the intrathoracic pressure, which is caused by respiration. And as your intracranial compliance decreases, you start to see pathological waves. And these pressure waves have been called Lundberg waves. Modern day practice, the emphasis on recognition and treatment of ICP means that we don't usually see Lundberg A waves, which is an ICP of 50 to 100 millimeters of mercury for 5 to 10 minutes. But I thought I'd just discuss these waveforms anyway, because it is useful.
So I've just had some information back from Mukund in India. Apparently they're a little bit behind with getting started. So I'm just going to rewind this presentation back to the start and just repeat the first 10 minutes of it. There's a few people in the lecture theatre that are just a little bit behind. So we'll give them a couple of minutes to start and we will be back with you shortly. This is probably a good time to say that if you want to get any questions in, please do send us a message. You can comment in the chat on YouTube, or you can send us a message via WhatsApp to +44 333 307. Sorry, I'll start that again. +44 333 303 0975. Send us a message on WhatsApp and we will try and answer your questions after. We should be joined by Dr. Deshpande, who'll be able to take you through any answers to any questions that you may have. Also, please send us some feedback. There is a QR code that'll appear on the screen. But in the meantime, we'll just hang on for the people in the hospital to get themselves ready, and we'll be back with you shortly. Once again, I apologise for the break. We're just waiting for the people in the hospital to get themselves ready, and we'll get back to you as soon as we can. We'll start the presentation again from the start. However, if you do have any questions, please send them in to +44 333 303 0975. That number is on your screen. And why not visit our Facebook page, facebook.com/SVJC UK, where you can subscribe and see our upcoming videos. These videos will also be available for you to watch whenever you want on YouTube. The links are on that Facebook page as well. So we're back with you in a couple of minutes and we'll start the presentation again from the start. I apologise to those that have joined us from the start, but we will try and keep up with everybody else. once again, we're just waiting for the people in the hospital to be ready, and we'll get started again. I apologise for the break. We'll start the presentation again from the start, but in the meantime, why not send us some questions? +44 333 303 0975. That number's on your screen. Okay, so we're about ready to go back to the programme now. So we'll start again from the start. Apologies for the break.
My name is Sarah Scott and I'm an ST6 trainee in Anaesthesia and Intensive Care Medicine, currently working at Freeman Hospital in Newcastle. In this talk, I'm going to look at intracranial pressure, what it is and why it's relevant, how we can monitor it and what to look for when you're monitoring, and then finally I'm going to discuss a little bit about how you manage raised intracranial pressure, and this will mostly be in the context of traumatic brain injury. So I'm aware you're going to have a talk on CNS physiology, so I'm not going to take up too much time reviewing that information during this presentation. But by way of introduction to the topic, I'd like to highlight the Monro-Kelly doctrine, which I'm sure you're already familiar with. This model describes the relationship between the skull, the cerebrospinal fluid, the brain parenchyma, and blood. So normally these exist in equilibrium. Therefore, if the volume of one of the CSF, brain parenchyma, or blood increases, then another must decrease. The CSF, the cerebrospinal fluid, is a dynamic pressure system, and your normal values for your intracranial pressure as an adult are between 5 to 15 millimetres of mercury, and for infants here under a year, it's 1 to 4 millimetres of mercury. So you can see on the picture on the right of your screen, in the normal state, as I mentioned, these all exist in equilibrium. Whenever you have an increase in one of these components, so as you can see in the middle of the three images, there is now a purple component which is representing a mass. So in order to maintain the intracranial pressure at within the normal limits, some of the venous volume and some of the CSF has exited, and that's then allowed the pressure to remain the same despite having to compensate for this increased mass. If you then look at the bottom of the three images, you can see that the mass has increased in size and it's squeezing out even more of the CSF, even more of the blood volume, and this is now a decompensated state. So I'm going to show you in the next slide how this appears. So you can see on the y-axis you've got your intracranial pressure, and on your x-axis you've got the intracranial volume. And again, slightly different colours representing different components, but pink for the brain tissue, blue for the blood, and yellow at the top for CSF. So in image 1, everything's normal, as you move along to the right, you start to see a little brown spot appearing, so you've got a mass, which is an addition to the components which are normally in equilibrium. So the pressure starts to increase. As this mass gets bigger, it increases the pressure further, and then it reaches a point where a very small increase, excuse me, a small increase in size of the mass leads to a large increase in intracranial pressure. So indications for monitoring ICP include traumatic brain injury, and this may be in the context of a severe head injury where the patient cannot be serially neurologically assessed, which may be because they have either been intubated and ventilated or they're unable to comply with the examination, or a severe TBI where they've got a Glasgow Coma score of less than 8 with an abnormal CT scan. And what we mean by that is the presence of a hematoma, contusions, swelling, herniation or compressed basal cisterns, or a GCS of less than 8 with a normal CT and 2 or more of age over 40, systolic blood pressure of less than 90 millimetres of mercury, or abnormal motor posturing. It can also be used in patients with hydrocephalus or impending hydrocephalus. It has on occasion been used for stroke patients, and it can be used in encephalopathy. So this diagram just gives you a crude overview of the brain. So you can see the labels in blue are identifying different parts of the brain, and the labels in green just demonstrate different ways in which you can place ICP monitors. So you can have an external ventricular drain, it can be tunnelled, or you can have an epidural or subarachnoid bolt. I'm going to talk a little bit more about some of these shortly. When considering any intervention, you have to weigh up the risks and the benefits. So I'll start with the benefits. You can have a continuous measure of ICP if you put in a monitor. In some cases, this can give you a visual waveform or it can give you a number. And this can be used to guide therapy. So if you see increasing ICP, which is dangerous for the patient, you can then intervene, do something and try and reduce the ICP. For many of these patients, you can't always examine them, so many times they are intubated and ventilated, so you may not see subtle clues that the intracranial pressure is rising before it's risen to a very high level. And with some of the monitors, you can drain some CSF or you can administer drugs into the CSF. So that would be beneficial in certain patient groups. As again, with any intervention, you've got to weigh up the risks to the patient. So these are invasive monitors, and with anything invasive, there's a risk of infection and a risk of bleeding. There is not very much evidence to suggest that these improve patient-centred outcomes. So there's a potential that you're treating the numbers, but that it doesn't translate into improved patient outcome at the end of everything. There is a risk of drift or of misinterpretation of the ICP, and if you start to think that the ICP is increasing to a dangerously high level, this may prompt you to do some interventions, but if you've misinterpreted the graphs or misinterpreted the trace, you may end up doing something harmful. And then there are risks associated with individual devices. So in the context of the bolts, you can't calibrate them. They're not a global measure, so they tell you about local changes only, which may not reflect the entirety of the brain. It doesn't give you any information about local perfusion, local metabolic activity, or oxygenation. You can't drain any CSF, and there is a risk of drift, which increases the longer that the bolt remains in situ. For an external ventricular drain, you need generally to take these patients to theatre to insert the drain. So you need the resource of the surgeon, the anaesthetist, the theatre team. It's a slightly higher risk of infection because you've got a direct connection with the CSF. And as with anything, although it should be clearly labelled, different colours, etc., to stop you inadvertently administering drugs into it, as with everything in medicine, if there's a chance that it can happen, it will happen, and so there is always a risk that drugs can inadvertently be given into the CSF when meant to be given intravenously. It can be technically challenging, so if the patient's got small ventricles or they've got a lot of cerebral edema, it may be a technically difficult procedure for the surgeon. So I'm now going to discuss some of the monitors in a little bit more detail. So this is an external ventricular drain, which is a temporary system that allows you to drain CSF from the ventricles into an external closed system. So it comprises of a measuring chamber, which is connected to a drainage bag. There's also a sampling port, which you might be able to see sort of halfway between the patient and the drainage system. You have to make sure that you zero the chamber, so this needs to be done at the level of the external auditory meatus, and then this allows you to increase or decrease the height of the drain, depending on whether you need to drain more or less CSF. It's a gold standard because ventricular pressure is more reflective of the ICP than subdural, extradural, or subarachnoid pressure. It's inserted in theatre, as mentioned, and via a burr hole, and you have a catheter then placed into the lateral ventricle. The transducer is remote from the patient, however you can transduce the tip. There are, as I've mentioned, there is a reasonably high infection rate, so 6 to 11%. This is increased if the drain blocks and it's flushed, and it increases further after day 5. So newer devices are impregnated with antibiotics such as clindamycin or rifampicin. It shouldn't be inserted if the patient has a coagulopathy, as the risk of bleeding is increased. Moving on then, this is an ICP bolt, which is a strain gauge tipped catheter, which goes in through the frontoparietal suture line in line with the pupil. So it goes through the dura either into the CSF or intraparenchymally. And whilst the EVD needs to be inserted in theatre on most circumstances, the ICP bolt can be put in at the patient's bedside. It's zeroed at the level of the external auditory meatus, but one of the disadvantages of the ICP bolt is that it may underread when pressures are greater than 20 millimetres of mercury. And as you know, the normal is between 5 and 15, so you're really not looking at a massively big increase before the accuracy of the readings starts to potentially become less. Once it's inserted, you can't calibrate it, and the ICP bolt can have a baseline drift, and this is more likely to increase after the 5th day of insertion. So you need to be mindful again of your readings and how long it's been in situ. So when you have an ICP trace, there are a number of different waveforms. So there's phase P1, P2 and P3, and with different names, so percussion, tidal and dichrotic. And the normal ICP trace should be pulsatile, which reflects both the cardiac and the respiratory cycles. The percussion wave correlates with arterial pulsation. The tidal wave is generated by arterial pulsation and the resistance from the intracranial parenchyma, so it represents intracranial compliance, and the P3 dichrotic waveform represents the closure of the aortic valve. The respiratory component is generated by changes in the intrathoracic pressure, which is caused by respiration. And as your intracranial compliance decreases, you start to see pathological waves. And these pressure waves have been called Lundberg waves. Modern day practice, the emphasis on recognition and treatment of ICP means that we don't usually see Lundberg A waves, which is an ICP of 50 to 100 millimetres of mercury for 5 to 10 minutes. But I thought I'd just discuss these waveforms anyway, because it is useful to know about even if you're less likely to see them. So the A waves, which you can see in the diagram on the left, and if you note the time scale, how that differs. So in the first picture on the left, your time scale goes up to an hour, whereas the two on the right, your time scale is in minutes. So A waves are a plateau shape with an amplitude of 50 to 100 millimetres of mercury that can last for 5 to 20 minutes. And these are always pathological and suggest low brain compliance. B waves you can see when patients are mechanically ventilated. So you get rhythmic oscillations, but the amplitude is much less. So it's less than 50 millimetres of mercury, and they occur every 1 to 2 minutes. These can suggest low brain compliance. C waves are non-pathological, and you see these synchronous with spontaneous variation in arterial blood pressure. So you get these rhythmic oscillations with an amplitude of less than 20 millimetres of mercury, and these occur every 4 to 8 minutes, and these are non-pathological waves. I'm now going to talk a little bit about managing raised ICP, and this is in the context of traumatic brain injury. However, many of the principles can be applied to raised ICP for other reasons. First of all, looking at respiration, you need to try and avoid hypoxia and avoid hypercapnia. If the patient is mechanically ventilated, you might want to consider using a volume-controlled mode. You must avoid a PaO2 of less than 8 kilopascals and saturations of less than 90%. Try to aim for a low to normal PaCO2, so in the range of about 4 to 5 kilopascals, but avoid hyperventilating the patient to lower their PaCO2, particularly in the first 24 hours. So you want to avoid sort of figures less than 4 kilopascals. When thinking about the patient's hemodynamics, try to maintain a systolic blood pressure of greater than 100 millimeters of mercury. For younger patients, 15 to 49, or older patients of greater than 70, have a systolic blood pressure of greater than 110 millimeters of mercury. And this is to allow you to target a cerebral perfusion pressure of 60 to 70 millimeters of mercury. If you've got a patient who's hypotensive because of hypovolemia, think about using 0.9% sodium chlorides for treating this and try and avoid colloids and albumin. Severe traumatic brain injury is increased with a SIRS response, so these patients may require a vasopressor or inotrope to manage their hypotension. If you continue to pour fluids into the patient, there's then a risk of causing edema. We've mentioned already the patient's likely to be intubated and ventilated, so make sure that they're adequately sedated. So we would use generally propofol and an opiate, and if you have their pain well treated, this can actually lower their intracranial pressure because of reducing metabolic demand, cerebral blood flow, therefore cerebral blood volume. It is not recommended to use prophylactic barbiturates to induce burst suppression in these patients. Caution though, if you're using propofol sedation for long periods of time, that you don't want to run the risk of patients having propofol infusion syndrome, so you might want to think about checking their triglycerides. So these patients may seize, so you need to treat them according to normal guidance. So start with lorazepam 0.1 milligrams per kilogram to a maximum of 4 milligrams. And then if you need a first-line regular anticonvulsant, you could use phenytoin or levetiracetam. With phenytoin, you have a loading dose of 20 milligrams per kilogram and a maintenance of 100 milligrams every 6 to 8 hours. Just remember that if you're giving this enterally rather than giving it intravenously, that you should stop the patient's feed for 2 hours before and 2 hours after to allow for absorption, and this can then cause problems perhaps with glucose monitoring and glucose maintenance. So just think about, if you're having the feed on and off, that you don't leave it for longer windows than is strictly necessary. If you're going to use levetiracetam, the dose for an adult patient is usually 500 milligrams every 12 hours. If you need to do a loading dose, we would usually recommend checking with your pharmacist about how to load adult patients. So managing the serum osmolality is another element of managing intracranial pressure, and you're aiming for a serum osmolality of 219 to 315. You can use mannitol or hypertonic saline. With mannitol, you're using 2 ml per kilogram of 20% solution, and you need to infuse this over 20 minutes into a large vein with a filter on your giving set. This can then be repeated 4 to 6 hourly if required. It should reduce the patient's ICP within some minutes, and it's got a half-life of 10 minutes, so it doesn't hang around for long. Please note though, this does cause a profound diuresis reasonably quickly after administration, so the patient should be catheterized. If you're not going to use mannitol, you can think about using hypertonic saline, and this leads to an increase in circulating blood volume and a rise in cerebral perfusion pressure. It does not have diuretic properties, unlike mannitol. And it can also modulate the inflammatory response, so reduce leukocyte adhesion to the endothelium. A typical dose might be something like 300 ml of 2.7% sodium chloride peripherally, but if you've got central access, you can use 150 ml of 5% over an hour, again to target your serum osmolality. Think about being cautious though if the patient has got chronic hyponatremia, because you've got a risk of central pontine myelolysis if you correct it too quickly. If the patient is hypovolemic or hyponatremic, think about using hypertonic saline. Otherwise, we would generally use mannitol. And as I've mentioned, the dosing is going to be different whether you've got a central line or a peripheral access. Other aspects to consider when managing a patient with raised ICP is their temperature, so try and avoid hyperthermia. Think about infection risk. If they've had a base of skull fracture, they're going to need a pneumococcal vaccine. Think about venous thromboembolism prophylaxis. So patients, unless they've had significant lower limb trauma, should have graduated compression stockings, plus or minus mechanical compression devices. And when you're thinking about transitioning to pharmacological management, it should be discussed with neurosurgeons really to come up with a risk-benefit for the patient if they've had any intracerebral hemorrhage. As I mentioned, nutrition, you should be starting enteral feeding early, but if the patient's had any kind of skull fracture, base of skull fracture, take care with your placement of your gastric tube. It may need to be orogastric, it can't be nasogastric. And then glycemic control. Hyperglycemia is bad for patients, so try and target a blood glucose of 6 to 10 millimoles per litre. I've just popped this diagram in, so this is what we use in Newcastle Trust, and it's our management for severe traumatic brain injury. Now I know this probably hasn't scanned particularly well, so on the next slide I'm going to show you that I've highlighted then your different levels of intervention with patients starting to have increase in their ICP. So we have a secondary brain injury chart, which is effectively all of those little components I've talked about, but it's a kind of checkbox list, so you can think about going through everything, make sure your ventilation's right, make sure your sedation's right, etc., etc. So make sure you're nursing your patient, simple things, head up 15 to 30 degrees, make sure you're not obstructing their venous returns, so we would not tie our tapes, we would use, we would not tie our endotracheal tubes in, they would be taped. And then if they have a collar on, you need to think about whether you need to loosen that. And if they're sedated and not going to be moving about, you could take off their collar. Make sure they're adequately volume replaced. Make sure that you've got an appropriate cerebral perfusion pressure. So that's your MAP minus your ICP. Check your ventilation parameters. Make sure you've got adequate saturations, adequate PaO2 and an appropriate PaCO2. Maintaining normothermia. And then again, optimizing sedation. If despite this, the patient's still got an increasing ICP, think about adding another agent in. So as I mentioned, we would use propofol and an opiate, so you could think about adding in some midazolam. If you need to boost the cerebral perfusion pressure, think about adding in a vasopressor, so something like noradrenaline. You can use cardiac output monitoring to guide your hemodynamic management. And then think about your osmolality, so think about whether you need some mannitol or hypotonic saline. If you're still worried that the ICP is increasing, you could think about paralysing the patient, so using muscle relaxant when you're doing stimulating procedures such as suctioning. And then active temperature management, so if they're starting to become hyperthermic, think about using cooling devices or external cooling for the patient. If the patient's ICP continues to rise even further, then you need to think about something like a decompressive craniectomy, and you need to discuss this with your neurosurgical team as to the think about adding in a vasopressor, so something like noradrenaline. You can use cardiac output monitoring to guide your hemodynamic management. And then think about your osmolality, so think about whether you need some mannitol or hypotonic saline. If you're still worried that the ICP is increasing, you could think about paralysing the patient, so using muscle relaxant when you're doing stimulating procedures such as suctioning. And then active temperature management, so if they're starting to become hyperthermic, think about using cooling devices or external cooling for the patient. If the patient's ICP continues to rise even further, then you need to think about something like a decompressive craniectomy, and you need to discuss this with your neurosurgical team as to the appropriateness of this, as to whether it's likely to confer any benefit to your patient or not. Then you've also got more involved interventions, such as thinking about a thiopentone coma, and we would suggest that you can use BIS to monitor your EEG, So you're not necessarily targeting your bispectral index number, but you're more looking for the trace. And if you cannot reduce the ICP, you can think about driving your cerebral perfusion pressure a little bit higher. But these are just some of the options that we would use, and this is our sort of flow chart. So I think I have come to the end of my time. Thank you very much for listening. There are references at the end, so I've taken a lot of the diagrams from teachmesurgery.com, so you can see that at the bottom, and then I've been using the British Journal of Anaesthesia education supplements for some of the detail. I've also included a link to the Newcastle Trust guidelines in case you wanted to have a look at the secondary prevention chart, if that might be something useful throughout your bed spaces. If anyone's got any questions, I'm more than happy to be contacted, and I'll try and answer them. If I can't personally answer them, I'll try and find out the answer for you. Thanks very much for listening, and enjoy the rest of your day.
Hello everyone, my name's Ella. I'm a specialty registrar in anaesthetics. I've been asked to talk to you today about fluid management in paediatric anaesthesia. I'm by no means an expert in this topic, but I have had the chance to learn from some people who are experts, so hopefully I have something useful I can pass on to you. I'm talking to you today from Durham, in the northeast of England, which is this lovely place, just for a little bit of context. Okay, we'll get into it. So we're going to cover a little bit of physiology to start with, just to remind ourselves. We're going to talk about types of fluids that might be available to us, how to work out a fluid regime for the patient in front of us, some practicalities on how we're going to go about administering that fluid, and then a little bit about blood products at the end, and some pitfalls. Just so we're all clear on definitions, a premature neonate is a baby born at less than 37 weeks gestation. A neonate is a baby that's up to 1 month old. An infant is a baby between 1 and 12 months old. And then preschool, school age, teenager, all a little bit more intuitive. So starting with physiology, the first principle to remember is that the younger the child, the greater the total body water and extracellular fluid volume. We can see here, from going back from 3 years old, approximately at the adult value, so a 3-year-old is 60% water, but a term neonate is about 75% water, and a preterm neonate, a very preterm neonate, about 90% water, so they're just little bags of fluid really. Again, a 3-year-old, in terms of extracellular fluid volume, the minority of their water is extracellular, but in neonates and up into preterm neonates, the majority of their water is extracellular. The second physiological principle to remember is that the younger the child, the greater the blood volume per kilo of body weight, obviously. So these figures vary a little bit depending on your source. But adult value, so an adult has about 70 mils per kilo of blood, dropping down to a neonate has about 90 mils per kilo of blood, and even 100 mils per kilo of blood for a preterm neonate. So the third principle to remember is that neonates really are a special case. We've seen they have high water content, high extracellular fluid volume. They have a high metabolic rate, so they have high water and electrolyte and glucose requirements. But in the first few days of life, during the postnatal adaptation phase, they have very low fluid requirements. So as the baby starts breathing air and the pulmonary vascular resistance goes down, we get increased venous return to the left atrium. That triggers ANP, atrial natriuretic peptide release, and the neonate has a postnatal diuresis. So that a neonate will typically lose weight in the first week of life, regaining its birth weight by about 7 days. And until that postnatal diuresis has occurred, we want to very much restrict fluid volume and sodium given to the baby. They have immature organ systems, so they have reduced concentrating ability in the kidney, so they can't generate concentrated urine, they can't deal with hypovolemia. And on the other hand, they have decreased GFR, so they have reduced ability to excrete large fluid loads. So they're vulnerable to both hyper and hypovolemia. If we look at the types of fluid that are available, this is going to vary a lot, obviously, depending on where you're working. But roughly speaking, we have crystalloids, which have a sodium chloride concentration. They may have a glucose concentration, and they may have other electrolytes. And then we have blood products, and just at the bottom I've put colloids, and we'll talk a little bit about colloids at the end. To look in more detail at crystalloids, so normal saline, sodium chloride 0.9%, the archetypal isotonic crystalloid. It's isotonic, but it has no potassium, it's acidotic, and it causes a hyperchloremic acidosis. And obviously is hypoglycemic unless there's been glucose added. And it actually has supraphysiological levels of sodium and chloride. Balanced crystalloids are a little bit more physiological, so we have Ringers, Hartmann's and Plasmolite. Again, it will depend what's available, it depends on where you're working. Again, these are isotonic, but they have minor solutes, so they have some potassium and magnesium and things like that. But similarly to a normal saline, they are hypoglycemic unless they have glucose added. Then we have the hypotonic crystalloids. So this is things like sodium chloride 0.45 and 0.18%. These were sort of the mainstay of fluids used in children for a long time, but really restricted now to special populations, normally neonates in those first few days of life, because they're very hyponatremic. And hypoglycemic again unless glucose is added. Then we have the pure glucose containing solutions, dextrose 5%, 10%. Obviously you can get more concentrated glucose solutions, but it's normally the 5 and 10% that are used as sort of IV fluids as opposed to for treating hypoglycemia. These have no electrolytes, they're very hypotonic. So then we have the mixtures, so normal saline with dextrose 5%, it's fairly common, and something like Plasmolite with dextrose 5%, and we can see immediately why they might be useful. When we're choosing what fluid we want to administer, we have to think about what we're aiming to do with the fluid. Traditionally, this is divided into covering a deficit, which may include resuscitation, providing maintenance fluid, and then providing for ongoing losses. And again, some nuances for neonates and some specific conditions. So we start with resuscitation fluids. Really, this is going to be an isotonic crystalloid, so normal saline or a balanced crystalloid without glucose, and 10 to 20 mils per kilo, and that's how you would treat shock. The caveat is if it's hemorrhagic shock, we're going to treat that with blood products, but we'll talk about that a little bit later. So for shock, if you want to give a fluid bolus, 10 to 20 mils of an isotonic crystalloid, and always without glucose. Move on to covering a deficit. So what is a fluid deficit? It's dehydration due to losses that have already occurred, so you're playing catch up here. Normal preoperative fasting doesn't normally cause a significant deficit that we need to cover, but certainly prolonged fasting or prolonged poor intake or diarrhea, vomiting, things like that can lead to a fluid deficit. The best way to quantify this is by weight loss, but you have to be lucky enough to have a pre-morbid weight for the child and to be able to compare that with the current weight, which obviously often is not available. So we move on to clinical signs of dehydration, and we say that 5% dehydration, mild dehydration, would be things like dry mucous membranes and the symptom of thirst. Moderate dehydration, increased heart rate, increased respiratory rate, and cool peripheries. And then severe dehydration, 15% of body weight, the child will be lethargic and irritable. Again, we want to be replacing this deficit with isotonic crystalloid, so that's normal saline or a balanced crystalloid without glucose. And the duration over which to replace will depend on the clinical situation. We've already said that if the child is shocked, we'll be giving a fluid bolus. So sort of implicitly, this isn't such an urgent situation. And normally a deficit would be replaced over a number of hours or even a couple of days. Moving on to maintenance fluids. So maintenance fluids are for ongoing normal physiological requirements. For the vast majority of children, normal saline or preferably a balanced crystalloid is absolutely fine for this. We need to think about adding glucose, 5 or 10% in neonates and infants. If you're asking a baby to go without a feed for longer than their normal period between feeds, then really we need to be giving them glucose, and particularly if they are under general anaesthesia and we don't have those normal clinical signs of hypoglycemia. There are other special patient groups at risk of hypoglycemia, so children with metabolic disorders, either they're at increased risk of developing hypoglycemia or they're at risk of ketosis and clinical deterioration if they're allowed to become hypoglycemic. Again, sort of neonates in the first few days of life are a special situation, and for their maintenance fluids, they will be receiving very low sodium concentrations, 0.18 or 0.5, with a significant amount of glucose. For determining the rate at which we're going to give maintenance fluids, we have two options. We have the Holiday Seagar formula, which gives us a daily maintenance fluid requirement, or we have the 4-2-1 rule, which is sort of derived from this and gives us an hourly fluid requirement. This is more useful in theatre because we think more in terms of an hourly rate to run our maintenance fluids. So the 4-1 rule tells us that we need to give 4 mils per kilo per hour for the first 10 kilos of body weight, and then 2 mils per kilo per hour for the next 10 kilos of body weight, and 1 mil per kilo per hour for each subsequent 10 kilos. The Holiday Seagar formula is almost exactly the same values, very slightly different. Neonates, again, are an exception. So in the first day or two of life, they need very much fluid restriction, so just sort of 50, 60, 70 mils per kilo of fluid. But once the neonate gets to sort of 5 to 7 days, they need much more fluid, so 150 mils per kilo per day. This is a daily amount because of that increased metabolic rate. You can see that the 4-2-1 rule, which we do often use in theatre, actually gives significantly less fluid than this. So if you had a 3.5 kilo neonate, 7-day-old neonate, getting, based on 150 mils per kilo per day, that works out at 21 mils per hour. But based on the 4-2-1 rule, at 3.5 kilos, they would be getting 14 mils per hour. So sort of significantly less. And I think this is sort of accepted because, firstly, in theatre, you're in a highly monitored environment and you can respond very quickly to sort of signs of hypovolemia and give extra fluid. And secondly, as we'll talk about a bit later, it's the tendency, particularly with the smaller children, is always to give too much fluid, especially when we add in drugs and flushes that we're using. And we can see that is detrimental. So better to give a little bit less as maintenance and to respond and give more if clinically required. So choice of fluid for replacing ongoing losses. So these are ongoing abnormal losses. That might be blood loss. It might be insensible losses from an open abdomen. And post-operatively, particularly, it might be GI loss from NG aspirates or from high stoma output. And we're going to replace these again with balanced crystalloid or normal saline, at least until our transfusion trigger is reached, if we're talking about blood loss. And we'll talk about that a little bit later. So how are we going to actually go about administering this fluid that we've calculated? Well, I would say as a good rule of thumb, it's safe to hang up a bag of crystalloid on a simple giving set which contains up to 20 mils per kilo body weight for the child in front of you. And it's all about safety. So if you accidentally or someone else accidentally opens up that drip set and the whole bag of fluid goes into the patient, you know you've only given them 20 mils per kilo, which is it's a safe and appropriate bolus to give to almost any child. Once the child starts getting smaller, or perhaps the surgery gets longer, or you need tighter control or more accurate control over the fluids you're giving, you can use a burette. So this is a chamber in a giving set which fits in between your bag of crystalloid and the patient, and we can very accurately measure up to 150 mils into this burette, and we can drip that in very accurately. Again, the idea is if you accidentally administer the whole contents of the burette quicker than you meant to, the most you will have given them is the volume in that burette. So you can hang a 1 litre bag of crystalloid, but if you've only dripped 50 mils into the burette then and you open the burette by accident, that's the most you've given. And you can measure really accurately on these. So these are good for in-between sized children. Once we get down to neonates, we're going to be looking at using syringe drivers. So if you're trying to give, like we saw before, perhaps 14 mils per hour to a neonate, then it's really hard to do without something like a syringe driver. Useful to have one of these narrow bore extensions for administering drugs and flushing through those drugs. The smaller the child, the more significant your drugs and flush volumes become. And if you're giving 5 mils of flush with every drug that you give, you can quickly give 20 or 30 mils of fluid, which can be quite a significant amount for a smaller child. So if you have one of these small narrow bore extensions and you know the volume of your particular extension, you can give just the right amount of flush to make sure that your drug has reached the patient. For administering a fluid bolus to a small child, we might want to use a syringe just so we have absolute control over how much we're giving. You might want to use this in combination with a burette, so you could measure 10 mils per kilo into your burette, and you could use a syringe and a 3-way tap to actually draw this out of the burette and syringe it into the patient. This device is a hotline, so this is a way of administering warmed fluids to a small child. So the warming element is in the box, and then it has this special coaxial giving set with your administration fluid in the middle, so blood or crystalloid, and then the machine recirculates warmed fluid as a little jacket around your administration fluid and keeps it warm right up until the end of the giving set, which isn't normally attached directly to the patient, but you can attach a 3-way tap and again a syringe and draw off that fluid, and it's warm right up to that point. For calculating post-operative fluids, we mentioned briefly why we might want to fluid restrict these patients actually. There are lots of reasons to restrict fluids post-operatively, especially in a critically unwell child. So the normal neuroendocrine stress response to surgery causes release of renin and ADH, so that will reduce urine output and decrease fluid requirements for the child. If a child's unwell enough to be on a ventilator, that again will decrease insensible losses and decrease metabolic demand, therefore again reducing fluid requirement. But even a child who's not critically unwell but is just a little bit inactive in bed will have reduced metabolic demand. Any lung disease will increase ADH and decrease fluid requirement. And we very much want to decrease or avoid the risk of edema and stress on suture lines and anastomoses. We know from adult practice that this can be a real problem. So it would be normal to fluid restrict your maintenance fluids down to about 70% of their calculated value post-operatively, in the knowledge that of course you're monitoring and you can always increase this if you need to. It seems far better to give restricted fluid initially and then to give a little bit extra if required. It's far easier to do that than to try and remove excess fluid if you've given too much. So just as a little example, if you have a 5-year-old who's 18 kilos, you can calculate their daily fluid requirement using the 150-20 rule. So they'll get 1 litre plus 400 mils, so about 1400 mils per day would be their total maintenance requirement, but we'll reduce that down to 70%, which is about 980 mils a day, and that's what you would be prescribing. Increased losses may well be important post-operatively, particularly nasogastric aspirates or high stoma output, and we would replace this normally mil for mil, like for like, with a sodium-rich fluid, possibly with the addition of potassium to best mimic the fluid that's been lost. So this needs to be thought about and measured and calculated and replaced. For monitoring IV fluid administration, a child that's needed 24 hours of IV fluids really needs to have their electrolytes monitored, and monitored every 24 hours for as long as they're on IV fluids. All of these calculations and guidelines are to sort of get you started, but you need to be measuring the sodium and the potassium and tweaking the composition of your IV fluid if necessary. For any child that you've thought it necessary to infuse glucose, you need to be checking a BM or a blood sugar every hour. Again, particularly if they're under GA and you're not going to see those normal clinical signs of hypoglycemia. So I've made some examples just to demonstrate how we might actually go about this in the real world. So we'll start with a 3.5 kilo, 4-week-old baby for elective hernia repair. So this is an elective procedure in a well baby that last had a feed about 4 hours ago. So we'll start by calculating their hourly maintenance fluid. So we'll use the 4-to-1 rule, and this will give us about 14 mils per hour as maintenance. We can calculate their deficit, so 4 hours times 14 mils an hour, about 56 mils. So a small volume. Losses are likely to be minimal. The abdomen is essentially closed and there'll be minimal blood loss. And it's good practice to calculate what you might give as a bolus, just so you've done the maths before the situation becomes urgent. So in this situation, on our first IV cannula, we might set up a syringe driver with a 50 ml syringe with plasmolite or perhaps normal saline with added glucose, and we're going to infuse that at the 14 mils an hour that we've calculated. We're going to have a second cannula because we don't want to be interrupting the supply of glucose by giving drugs and flushes and fluid boluses. So a second cannula with a narrow bore extension, and we might consider sort of covering for the deficit by giving a manual bolus with a syringe of 10 mils per kilo, 35 mils of plasmolite or normal saline without glucose, perhaps at induction to sort of cover some of this deficit. And because we're infusing glucose, we're going to check the blood sugar at an hour. Post-operatively, the babies like to be feeding again quickly, and we shouldn't need to prescribe any IV maintenance fluid. Another example, a 25 kilo, 5-year-old having elective adenotonsillectomy. Again, a well child, and perhaps they had some water just an hour ago. We'll start with calculating their hourly maintenance rate, again with the 4-to-1 rule, which gets us to about 65 mils an hour. Fluid deficit is really going to be minimal because they had a drink an hour ago. About 65 mils, sorry, that's a typo, that should be 65. Losses, again, likely to be very small, even with a little bit of bleeding. And again, we'll pre-calculate what we might give as a 10 per kilo bolus, just so we have that all calculated and ready. So in this situation, we can use a single IV cannula. We can set up a 500 ml bag of perhaps normal saline, 500 mils being 20 mils per kilo bolus. So 2 times 250, and we can run that in freely. And we might try and approximately give half of that quite quickly as a bolus, and then run the rest through slowly through the rest of the operation, knowing that if by accident we run the whole 500 ml bag in, we've only given 20 mils per kilo, which would be very much safe and appropriate. Again, post-operatively, they're likely to be at least drinking soon after the operation, if perhaps not eating. And with a 5-year-old well child, a low risk of hypoglycemia, so no IV fluids required post-operatively. Slightly more complicated situation, a 12 kilo 2-year-old having a laparotomy for a revision of a stoma. Maybe they've been unwell for a few days, they've had poor oral intake, they've been vomiting, and at admission they were estimated to have 5% dehydration. So again, we'll start with calculating their hourly maintenance using the 4-to-1 rule, and that brings us to about 44 mils per hour. The deficit in this case would be 5% of 12 kilos, which is 600 mils, and that's been sensibly replaced over about 24 hours by adding 25 mils per hour, so 600 divided by 24, adding that to the 44, so just giving a slightly increased maintenance rate. Losses, there's a laparotomy, so an open abdomen with increased insensible losses. These are not routinely sort of estimated and replaced anymore, again in recognition that the tendency seems to be to over administer fluid, so we're not going to formally calculate that bit, but we'll just be mindful that the insensible losses will be greater. And again, we're going to work out what our 10 mils per kilo bolus is going to be, just in the case we need to do that in a hurry. So the child's come to us with the deficit already corrected, which is good. So again, we're going to have 2 cannulas. On the first cannula, we've got the maintenance running. Perhaps we're going to use normal saline with potassium because this child's been vomiting. On a second IV cannula, again, we don't want to interrupt the flow of this, so we're going to have a second cannula. And we're going to have a bag of plasma light running through a burette with a 3-way tap between the burette and the patient. And if we want to give fluid boluses, we can measure out 120 mils and we can push that through with a syringe if required through the 3-way tap. So post-operatively, the child will need some IV fluids most likely, but now we're going to restrict down the maintenance fluids to 70% of their 44 mils an hour, so down to 30 mils an hour. And we're going to make sure we measure and document and replace any NG aspirates with 0.9% saline. So we'll just talk a little bit about some pitfalls of fluid administration. First thing is hyponatremia, and I mentioned earlier that often hyponatremic fluids, so sodium chloride 0.45 or 0.22 or 0.18 was sort of the mainstay of IV fluids for children, but this has really changed. It's sort of dangerous really to give hyponatremic fluids, especially to a child who's losing sodium rich fluids, so they're vomiting or they have diarrhea. Symptomatic hyponatremia we're going to treat with a very concentrated sodium chloride solution, 3% at 2 mils per kilo, repeating until we have some stability. But we don't want to correct up to normal quickly at all. We don't want to correct by more than about 0.5 millimole per hour because of the risk of going too quickly. Really, if we're giving appropriate maintenance fluid, so normal saline or a balanced crystalloid, then hyponatremia should be much less of a problem. Hypokalemia, very much a possibility if we're not measuring and adding potassium to our maintenance fluids. If you're giving a concentration of greater than 40 millimoles per litre, this requires central vein administration. And we don't want to, again, administer more than 0.5 millimole per kilo per hour because of the risk of too quick a change and arrhythmias associated with that. But again, this is a good reason for measuring electrolytes regularly because the potassium concentration in the plasma is very hard to predict, and we might need to add or take away potassium from our maintenance fluids quite regularly. Hypoglycemia, we need to very much be aware of the patients who are at risk of this. We've mentioned neonates and young infants if we're asking them to go for a long time between feeds, but also older children who are malnourished, children who've had extensive regional anaesthesia as part of their anaesthetic technique, because this abolishes the normal stress response to surgery and the hyperglycemia that would normally come with that. A child who's been on TPN and had that stopped suddenly is at risk of hypoglycemia, and as we've said, children with metabolic syndromes. And we're going to correct hypoglycemia with 2 mils per kilo of 20% glucose, or an equivalent amount of a more or less concentrated glucose solution. Hyperglycemia, often measured in children after major surgery, particularly because of that stress response. So another good reason not to administer IV glucose to older children. They really generally don't need it. So I'll move on to talking a little bit about blood products. In my mind, there are sort of 3 situations in which I might be giving blood products, and I might give them differently in each of these situations. So we'll start by talking about resuscitation in hemorrhagic shock. And really, simply, if a child is hypovolemic because of hemorrhage, if they're in hemorrhagic shock, they need blood products. They don't need crystalloid, they need blood products. And I've taken these numbers from my local hospital's major hemorrhage protocol, but the principles here are to give small amounts and reassess and repeat, and also to give a balanced transfusion, so balanced amounts of red cells and FFP, and starting to give platelets and cryoprecipitate, so a concentrated fibrinogen source, once you've given about 3 lots of red cells. So typically ratios of 3 red cells to 3 FFP to 1 platelets, or 4 to 4 to 1 would be quoted. But the principle is to give them in a balanced way, and not simply to give loads of red cells. Slightly different situation in theatre, so we're seeing bleeding and we want to replace that blood loss. What we want to do preoperatively is calculate our allowable blood loss. So this is the amount of blood we're happy for the child to use before we think we might need to transfuse. And we calculate this by deciding our minimum acceptable hemoglobin. Now, most children will be fine with hemoglobin down to 70, but in a situation with ongoing blood loss, we want a little margin of safety. So we might say our minimum acceptable hemoglobin is 80. We measure the preoperative hemoglobin in here, and then we calculate the child's blood volume using this table that I showed to you earlier. So as an example, if you have a 1-year-old who weighs 10 kilos, we've measured their starting hemoglobin at 130, really good value, and we've decided that their transfusion trigger during surgery is going to be 80. We can estimate their blood volume by, up here, 80 mils per kilo times 10 kilos will give us 800 mils. And then we plug these numbers into the equation here, and it tells us our allowable blood loss is about 307 mils. So we can ask the scrub team to be measuring blood loss by weighing swabs and looking at what's in the suction. And when we're getting anywhere near this, we can be thinking about transfusion. Just a quick word on transfusion triggers. As I said, 70 is appropriate for a stable, non-bleeding, acyanotic child, but a child with cyanotic heart disease or severe respiratory disease, or who is actively bleeding, will need to have a higher transfusion trigger than this. And then moving on to blood product replacement in the post-operative period. So in this situation, perhaps your child is hemodynamically stable and they're not bleeding, but you're measuring the full blood count, and you might be looking at the coagulation screen and seeing abnormalities there. And these are the sorts of volumes that you'll see quoted for replacing these various things. So we say that 4 mils per kilo of packed red cells will increase the hemoglobin by about 10 grams per litre, or 1 gram per decilitre, depending on what your units are. And then these are the often quoted volumes for replacement of these various components. 10 to 20 mils per kilo of FFP, 10 to 20 mils per kilo of platelets, and a bit less for the cryo. We can't really mention blood transfusion without talking about its place in the wider patient blood management. So the whole aim of this is to reduce anemia and also reduce the requirement for blood transfusion, in recognition that both of those things generally lead to more adverse outcomes. So preoperatively, we want to be detecting and treating anemia, for example, with iron. Intraoperatively, lots of things we can do to reduce blood loss using tranexamic acid, patient positioning to optimize venous drainage, avoiding hypertension. Perhaps if it's appropriate, using hypervolemic hemodilation, so giving a little crystalloid bolus before any bleeding has started, so that simply the number of red blood cells in any blood lost will be less. Optimizing coagulation by keeping the patient warm. Surgical technique we don't have such a large say over, but regional anaesthesia, which may help reduce bleeding, and cell salvage, certainly if it's available. And then post-operatively, it's about optimizing anemia tolerance, so ensuring there's good oxygenation and euvolemia, minimizing oxygen consumption, perhaps by treating infections and reducing pyrexia. So just to show where blood transfusion actually fits in the wider picture. I said I would talk a little bit about colloids. It is a very little bit, really just to say there's no clear evidence of benefit of colloids over crystalloids. Theoretically, of course, the idea is that they remain in the circulation for longer and increase intravascular volume for longer. But outside of particular situations, perhaps neonates, perhaps cardiac surgery, really there's no clear evidence of benefit. There is, however, definite increased risk of harm from renal failure or allergic reactions. So that's all quite woolly, but what I do know is that I just don't see them used very much intraoperatively. So for me, that's sort of the bottom line. So my take-home messages from this talk are that balanced crystalloid or normal saline are fine for most children, and think about adding glucose really if they're less than about a year old. Use the 4-2-1 rule for calculating maintenance fluid requirements in theatre, or the 150-20 rule for calculating a daily maintenance requirement. As a rule of thumb, it's safe to hang up a bag of fluid if it contains no more than 20 mils per kilo body weight for that child, safety being the word there. Restrict fluid after major surgery, particularly. You can always give more fluid if required. And neonates are very much a different species, which require their own talk. These are some of my references, 2 very good books there, and some papers you might want to have a look at. I've put my email at the top. I'm very happy to be contacted about any thoughts or questions. If I don't know the answer, I will certainly be able to find someone who does. So do please contact me if you'd like. Thank you very much.
So we'll just take a short break there, 5 minutes, stretch your legs, stand up, have a wander around. Get any questions in that you have, please do send those in. You've got the numbers on the screen, +44 333 303 0975. You can send that through WhatsApp, or you can send us messages in the chat on YouTube if you're watching at home on your own. But please do keep those questions coming in. We'll be joined afterwards, after the next presentation, by Dr. Deshpande, who will also be able to answer any questions. If we haven't replied to any questions in the comments, we will get to them. We may message you later on in the day. Some of the things need a little bit of research, but we will get back to you. So please just stand by. We'll be back with you in a few minutes. Once again, please do keep those questions coming in. Use the QR code on the screen or send them to +44 333 303 0975. We also want your feedback. There's a QR code that will appear on the screen as well for your feedback. If you can hold on till the end, that would be great. I'll also put the link into the YouTube chat so we can get all your feedback, all your ideas, what you liked, what you didn't like. It really does help us to keep this going. We'll be starting again in a couple of minutes with a talk from Dr. Sarang Puranik on chronic pain and pain in cancer patients.
Good morning. I'm Dr. Sarang Puranik. I work as a consultant in anesthesia and pain management at Kingston Hospital in Surrey. I'm going to talk to you about nerve blocks in cancer pain. It's quite a big topic to fit in half an hour, but I'll try my best to give you an idea about most of the commonly used blocks and overview. We know about cancer pain. We know that cancer pain is underdiagnosed and it is undertreated. But 70 to 90% of all cancer pain is generally controlled with WHO ladder. So starting with mild to moderate pain control medication, going up to morphine and stronger pain opioids such as oxycodone as well. But for those with unrelieved pain, invasive procedures have an important role to play. An appropriate use of these can relieve most of the cancer pain. So coming to what causes cancer pain, directly caused by cancer constitutes 53%, caused by cancer treatment about 14%, caused by cancer related debility 25%, and some pain can be completely unrelated to cancer, which constitutes 8%, such as other areas including muscle pain, etc., as well as back pain. 75% patients with advanced cancer get pain. Roughly 1/3 of those with pain have one pain, third of them have two pains, and third more than that. Quite a few patients have more than one distinct anatomical sites of pain, and 1/3 seek more drug therapy than what they have been initially prescribed. Almost 1 in 10 though want to reduce their medication because of various issues, including side effects and other problems. You will see that many cancer patients do not seek treatment, and the main reasons are perhaps expectation. A lot of people think that pain is an inevitable consequence of cancer, and they leave pain relief until the end. You will see a lot of ethnic differences in terms of when patients ask for pain relief. In Asian countries, they are very late to ask for pain, for example. There is also issue of availability of medications such as morphine and other strong opioids may not be easily available in India. And then there is fear of side effects such as addiction, constipation, which can actually cause more problem than pain relief, and confusion. So if you look at the pyramid of the pain, most of the pain relief is obtained with the help of disease modifying therapies. The next being pharmacological palliation, followed by psychological and nursing intervention, and only the tip of this pyramid can be obtained with the help of, or needed as well, with surgical and physical procedures. How to divide those invasive procedures? They can be classified according to target, autonomic nervous system, peripheral nerves, and neuraxis or neuraxial blockades. It is believed that autonomic nervous system carries afferents of the pain, and hence they are most commonly used site for pain relief in cancer. So if you look at the number of blocks and which blocks are commonly used, this gives the list. The stellate ganglion block is used for head and arm pain, celiac plexus for pancreatitis pain and cancer, abdominal pain, and visceral cancer pain. Interpleural block can be used for head, arm, thorax, lung, as well as bladder and abdominal organ pain. Lumbar sympathetic blocks, usually for lower limb pain. Hypogastric plexus for perineal, pelvic, and lower limb pain. And sacrococcygeal ganglion or ganglion of Impar, used for rectal pain, for example, and Gasserian ganglion for trigeminal neuralgia and facial pain. Coming to stellate ganglion, the stellate ganglion lies anterior to the lateral process of C6 or C7, and it carries autonomic pathways to ipsilateral head and upper extremity, and hence the block is helpful for those. If we are going to use local anesthetic, generally serial blocks have to be done in a few weeks interval time, but you can use dilute phenol in concentration of 3 to 6% if you need to use long term, but you need to be aware of the consequences, which we'll discuss later. But radiofrequency neurolysis is something which is available these days, and that doesn't cause much of motor problems and frequently used for this as well. This area, as you will be aware, consists of a lot of important structures, and serious consequences can happen, and you need to be aware of those, like injection into vertebral artery, phrenic and superior laryngeal nerve block, and intrathecal injection can happen as a side effect or complications. This is the anatomy of stellate ganglion block. As you can see, the ganglion lies very in close proximity to carotid artery in front of longus colli muscle. This is the picture if you want to do block with the help of ultrasound, and you can see the picture on the right side in the corner, longus colli muscle again, carotid artery, thyroid gland on the left, and the needle coming on top of the longus colli muscle close to the C6 tubercle. And the ganglion is very close to carotid artery, as you can see. But you can also do this under fluoroscopic or X-ray guidance. In this case, patient lies in supine position. You obtain 25 degrees oblique foraminal view, and the target is junction of vertebral body and uncinate process of C6. You check with AP and lateral view, and the contrast is injected to see the spread, and then about 10 ml local anesthetic is injected. Coming to celiac plexus block, it's fairly long established block. The celiac plexus lies anterolateral surface of aorta at around T12 to L2 area, and there are different approaches used to do celiac plexus block, such as splanchnic block, splanchnic, anterocrural, retrocrural, transaortic, and anterior. Retrocrural or posterior approach is commonly used, and selection of block is done depending on the patient's ability to lie in certain position, and also depending on where the tumor is. If it is in the more sort of anterior area, you may not be able to reach, and then probably most of the time easier to approach and less chance of any other important injury, you could use posterior approach, etc. Again, this is a picture of anatomy of celiac plexus block. As you can see, around 7 centimeter from the spinous process, the needle is approaching, and it's lying just in front of aorta here, and again goes through very close to kidney at around L1 to with the T12 and 12th rib area. It gives good short and long-term relief in 70 to 90% of the cases, and the common side effects are local pain in 96% of the patients, hypotension fairly common, diarrhea more common in antecrural approach, and then serious consequences such as paraplegia or bowel and bladder dysfunction is also known. Another commonly used block is ganglion impar block, and it's fairly easy to do block with very few side effects, and it's really good to know if you're treating various kinds of pain. The ganglion is known as ganglion of valvar or sacrococcygeal ganglion, and its only unpaired retroperitoneal ganglion, which lies anterior to sacrococcygeal junction. It's been used for a long time. First use was in 1990, used for intractable perineal sympathetically mediated pain. For example, pain due to celiac cervix, rectum, endometrium, as well as bladder. Pain due to this can be referred to rectum, perineum, or vagina, and most of the times the characteristic of pain is like vague or poorly localized, and it's usually accompanied by sensation of burning and urgency. This is the X-ray radiographic view. As you can see, initially this is on the outer side. You can see the needle passes through and through between the coccygeal sacrococcygeal membrane, and the contrast is on the anterior side of the coccyx. Another block which is used usually quite successfully for surgical anesthesia is interpleural block. It's also good for alleviation of acute exacerbations, and it's supposed to work by somatic as well as autonomic blockade. Most of the time the deposition is due to gravitational force, and it is believed that it could be leading to diffusion into brachial plexus and even cervical sympathetic block when the local is deposited between the two layers of pleura. Important side effects to note and be careful about are pneumothorax, infection, and possibility of toxicity because local anesthetic spreads easily in the pleural cavity. A lot of peripheral nerve blocks can be used depending on the position of the tumor, such as intercostal nerve blocks, ilioinguinal nerve block, lumbar plexus block, femoral nerve block for lower limb pain, nerve root blocks for pain if it is in the dermatome of that particular nerve root. And a lot of times you can use local anesthetic and steroid combination, which may give you few weeks to few months relief as well without any permanent consequences. If you need a long-term block or short-term block rather without issue of problems of sensory or motor nerve damage, then you could use neurolysis, and we'll talk about what are the agents used for that, but you need to be really careful when you want to do those blocks with the help of neurolytic agent. Coming to neuroaxial blocks, they can be subarachnoid blocks, epidural blocks, or caudal epidurals. As I mentioned about neurolytic blocks, two commonly used agents are alcohol and phenol. Alcohol is generally used for subarachnoid blocks and celiac plexus block, and phenol, for example, is used for lumbar sympathetic nerve blocks and also peripheral nerve blocks and ganglion impar and superior hypogastric plexus blocks. Although different authorities have used these two agents for other blocks as well. What you need to remember in terms of alcohol, usual concentration used is 50 to 100%, and it acts by destroying nerves and producing Wallerian degeneration without disruption of Schwann cell sheath, extraction of cholesterol and lipids, and precipitation of proteins. Clinically, it is hypobaric with specific gravity of 0.8 relative to CSF, which has specific gravity of 1.1. So the target site should be above the site of injection. And if you compare it to phenol, the concentration used is generally 5 to 10%, and commonly used agent is phenol in glycerin. It causes more large diameter fibers than the smaller fibers, and it destroys axons along the dorsal roots and posterior columns without disrupting cell bodies. And it is hyperbaric as compared to CSF. So the target site should be below the site of injection. Subarachnoid blocks are used because there is a physical separation of sensory and motor roots, but selection is the key for these blocks. Pain should be localized to 2 to 3 dermatomes and should be predominantly somatic pain on one side. And as we discussed, we have tried all other avenues before trying subarachnoid blocks. The side effects should be explained, and as if you are going to use neurolytic agents, patients will lose bowel, bladder function and some other side effects because of the neurolysis. So patients as well as relatives should be always warned about the consequences, and they should always be followed by local anesthetic blocks trial to see if they are really helpful initially. We can also use spinal opioids, especially in patients who are opioid resistant or had toxicity because they had to use extra large doses of opioids otherwise systemically. So which opioids are the best? Ideal drug should be water soluble, so it gives longer duration of action and more extensive spread, and should be highly potent, so lower fractional receptor occupancy causing lower tolerance. Obviously, there may not be the ideal agent always available, but morphine comes as close as we can imagine, and that is the commonly used opioid in spinal opioid. Mechanism of action is, it is believed that there are some endogenous spinal opioid receptors, and in fact, as back as 1979, when first use of intrathecal morphine has been recorded. The advantage of using them in spinal form is that you will get less side effects with smaller concentration. If you are going to use drug delivery either intrathecally or epidurally, there are different ways you can use them. In fact, there are 5 types of indwelling epidural and spinal delivery methods. Type 1 is percutaneous with tunneling, as we normally use for some of the longer surgeries, for example, and that's used fairly commonly because of the safety, and you can use either epidural or spinal catheters, especially for patients who have less than 3 months of life expectancy. Then type 2, where you can use implantable device with subcutaneous injection port such as Portacat. Type 3 is pulsatile implantable devices such as Algomade, which are a bit sophisticated and require surgical implantation. Then there are type 4, which are implantable gas driven such as Infusaid, where you get continuous infusion system. And then type 5, which are completely programmable and implantable like Synchromade, and rate can be adjusted by telemetry. Important things to remember, even in the spinal form there are side effects, but respiratory depression is very rare. For urinary retention, pruritus, sedation, and even tolerance can develop after 6 months. Other problems with implantable devices such as mechanical, like fracture of the device or the cannula or the catheter, and infection are also known. There are few other spinal drugs which are also used, such as clonidine, which is alpha-2 agonist, but you have to be careful because it can cause sedation and hypotension. Then there is benzodiazepines and baclofen, which are GABA A and B agonists. Recently, in the West, because of cost generally, but ziconotide, which is N-type calcium channel blocker, is also used. Again, it's important to remember there are side effects which you need to be aware, and it can cause permanent damage as well. Then there are NMDA receptor antagonists, ketamine, and then NSAID and neostigmine can also be used, and steroids, which is fairly common as we mentioned before. But what is also important that there are other aspects associated with cancer pain, which could be because of non-malignant pain, such as neuropathic pain due to pressure on the nerves and discs, which can be associated. Then there could be debility-related musculoskeletal pain because of not able to walk and may not be able to do exercise, etc. Then the patients may get a lot of muscle spasm where you may need to use muscle relaxing agents such as botulinum Botox toxin and trigger point injections with local anesthetic and steroid. Physiotherapy as well as stains, etc. are also equally. In summary, in small minority, interventions have a definite role. Timing is everything, and therapies need to be provided with skill and caution, because as we mentioned, you need to be aware where exactly is the tumor site, as well as other medications, such as the patients may have been on anticoagulants and other heart problems, etc. And then it could be invading tumor and vascular tumor, and you need to be really able to do this with important caution and skill. And most of these blocks are offered in a multidisciplinary framework of care once you have tried all other options first. And generally, when and if they have failed, various interventions can be offered. Thanking you.
So we're going to be back in a few minutes. We're going to be joined by Dr. Sanjay Deshpande. So if you do have any questions, please do send them in to WhatsApp +44 333 303 0975, or you can comment in the YouTube chat there, and we will get back to you as soon as we can. We're going to be joined by Dr. Sanjay Deshpande in just a couple of minutes. So, as promised, we're now joined by Dr. Sanjay Deshpande, who will be here to answer any questions and just say a few words.
Good morning. Well, it's good afternoon to you, all of you, and I hope you are enjoying the learning from these talks from my colleagues who have actually spent a lot of time preparing these talks, and I'm sure you enjoy. I'm happy to answer any questions.
There's one message that was that came through on the chat that I sent you on WhatsApp, Dr. Deshpande, around. If you find that question. Chat. So there's a question came in during Ella's presentation, looking at crystalloid use in paediatrics. In hemorrhagic shock, how much crystalloid to blood ratio is necessary in the golden first hour?
I think the ratio is 3:1. So three times crystalloids to 1 time of unit of blood. Certainly, you give fluids in proportions of 10 to 20 kg per kg body weight, and see the response. And as Ela mentioned, when you lose more than 10% of the blood volume, depending upon the hemoglobin, you probably may have to consider transfusion. So that is something which you need to consider in the background, and obviously it's important that you try and stop the hemorrhage wherever the source is. So that is something the surgeon will need to focus on to try and stop the bleeding.
That's really all the questions that we've had come through. So if anybody does have any, please do send them in. We'll hang around for another 5 minutes or so, see if any questions come in. Have you got anything you would like to say, Sanjay?
So what I'm talking to on this particular thing is the audience able to hear?
Yes, everybody can hear you.
Okay. I can't hear anybody's voices, so.
Yeah, I can't hear anybody else either. It's just me and you talking to everybody.
Okay. Thank you.
Just wait to see if any more questions do come through.
That's absolutely fine. Well done, Ian.
We've had a busy week this week, putting all this together. There are still a couple more days to go, so there's plenty still to come. Remember, all these videos are available on YouTube forever. And if you use our Facebook page, www.facebook.com/SVJCUK, the links are all there to all the videos, and you'll be able to revise them, review them at your leisure whenever you want. But for now, unless any more questions come in the next couple of minutes, unless you have anything else to say, Dr. Deshpande?
That's absolutely fine. If they were satisfied with the lectures which my colleagues did, just want to request the audience to give a big hand for all the speakers. So at least I can hear your big hands.
That's fantastic. Well, thank you very much for joining us today. Remember, these presentations are live forever, so you'll be able to revise them at any time you want. And we'll say thank you very much to Dr. Deshpande and all the speakers from today.
Thank you very much. Thanks, Ian, and for organizing this wonderful sort of. That's the most hard job, and well done to you.
Oh, it's been a pleasure. Hopefully, we'll be back out there next year and won't have to do it this way again.
Absolutely. Looking forward.
Thank you very much, and thank you very much, everybody.
Okay to switch it off?
Yep.